Hello, welcome to First Friday Live. Oh, wait a minute, we may not be started here. It's still thinking about whether to go live. Okay, now we're going live. Hello, I'm Dr. Perry. Yes, boy, I wish I could edit it. This is unfortunately going live, so you can see that it is actually real. We've been going back and forth with a little bit of new settings to Facebook as well as some new technology here. So good to have everyone streaming and paying attention, and thank you for joining us today. Today we're going to be talking about IVF. So there are all kinds of things that we're going to do. Hey Alexis, how are you? We're going to do everything IVF. So the core questions that I had for today, we're going to be sort of what is IVF, why do we do it, who needs it, who gets pregnant from it, because it's actually much more predictable than many people realize. Hey Tamika, we'll talk about how much is IVF. Great question for things. We'll talk about day 3 versus day 5, fresh versus frozen, all that alphabet soup, the ICSI, assisted hatching for AH, PGT, endometrial receptivity assays, all those types of things. So we will answer all these things. But first I was going to give Brittany, who's right here, she's going to let her come in, give a few words for the common sense from the streets. By the way, everyone who's online, you got to wish and congratulate Brittany. Congratulations on passing her nurse practitioner boards. She's been with us for 5 years, and I've known her from regular nurse. Now she's leading the team and an NP. So congratulations to Brittany. She's going to come on over, say a few words, and then I'll be back and start answering some of the things that I was going to say.
Okay. Hello, everybody. Okay, yes, I can see the comments too. Perfect. Thanks, Rachel. So sweet. I love you. Okay, so from my point of view, thank you, Alexis. From my point of view, I just wanted to kind of tell you what we see from a nursing point of view that are some of the main questions. And I'm not scripted, Dr. Perry's better at talking, so I have to write some of mine down. One of the questions I get is, well, first, let's go back to the emotional part of it. I love how Miss Vicky always says, you just have to put on your blinders and keep focused on the end game. And I always say, keep your mind focused on sitting in the hospital, holding that precious baby, and let us do the rest. If you do what we tell you for IVF, you're going to be good to go. And we are always very open for questions, concerns. We love our patients. We don't want you consulting Google for any of that. We would love you to call us for questions that you have. So that's the first thing. But one of my main questions I get, tell me about these shots. So it starts off, you'll just be taking one shot a day, about 14 days, as far as the shot part of it goes. And it is a tiny little needle, same size needle that people give insulin with 5 times a day. Super small, goes in the belly. It is not bad. And it's not bad to learn that one as your first shot. So that's how it starts off. And then you go up to 3 shots a day when you get in the stimulation phase. And those are all 3 in the belly too. There is one that people say burns more. But they're not bad. They're tiny needles too, and so you are usually good to go. So you kind of build your way up to the shots and how you're doing them. A lot of people have already done the HCG injection by the time that they get to us. They've normally done inseminations or something first. That's your first intramuscular shot. You do that one 2 days before the retrieval. It's not bad. It's a good starter shot to get you ready for giving the progesterone injections. I'm sure a lot of the patients would tell you they read horror stories about that one, but we give you nice tips and tricks to make it not as bad, hopefully. And so we try to, teach family members how to do it, try to direct you to videos to watch how to do it yourself. Although that person on there is very flexible, not everybody can be like that. So those are the main things to tell you about shots. They're not as bad as they seem. Other things, so typically, people like to know kind of what's the schedule for when you come in and do things. So typically you'll have a consenting appointment where we consent, go over teaching, do blood work on both partners, all that good stuff. So that pretty much can be at your convenience. And then in whatever time of the day, morning or afternoon, it doesn't matter for that one. And then people typically will have a baseline ultrasound, which is a few days before your stimulation starts. Stimulation typically starts on a Friday. And that one, it can be morning or afternoon also. We're just making sure you're good to go. Then during the stimulation phase, you're here usually Tuesday, Thursday, Saturday. And then the following week would be the retrieval week, and the week after that would be transfer week. And so we always do the day 5 transfers typically. Dr. Perry will talk about that in a minute. But that's 5 days after the day of the retrieval. So that's just kind of a timeline. One of the most important things before we do any of this, because we do for the retrieval, you're put to sleep. You have propofol, so you're kind of, for any of you who've had your wisdom teeth out, you're asleep, but there's no tube down your throat or anything like that, and you don't remember anything, you don't feel pain or anything like that. But we do ask that before you're having that, drink plenty of fluids, because you would be bloated, and we need your veins to be good for starting an IV. And so retrieval, it's really not bad. You think of having a procedure and you have to stay there all day long, and it's not like that. Like, we have a well-oiled machine as far as that goes, and our anesthesia is wonderful. Like, the whole team that does that, just wonderful, and you feel so at home. And then the transfer, pretty simple. You'll get a picture of your little sweet embryo, and I've actually heard of people having like paintings and stuff made of their embryo, and it'll be on their living room wall, but nobody really knows what it's for. So I thought that was a cool idea, but partner can be in the room for that. You'll kind of see on the screen as it goes in. So it's just a really cool thing. And like I said, that's 5 days after the day of the retrieval, not including retrieval day, typically, unless he does otherwise. And so that's just really cool. And then you find out 10 days after that if you're pregnant. So it's like the longest 10 days ever. So I always say stay super duper busy during that time to try to keep your mind off of it. Oh, we love you too, Hannah. That's sweet. And so that's kind of all I have to say about it, just from the nursing point of view, because we're the ones who are always like, what's my schedule going to be? When do I have to come in? How are the shots and all that good stuff? But we're always here to answer your questions, any that you may have. So I'm going to give it back over to Dr. Perry.
Okay. Tag, I'm in.
Yep, tag, you're it.
I'm back. Okay, so we're going to cover a lot more things. And by the way, for a lot of the stuff I talk about IVF, for a lot of the details, how you go about timing medication, for instance, we break the medication teaching from the nurses down into 3 parts so that ultimately there's sort of the synchronization, getting the eggs lined up, there's the stimulation, getting the eggs to grow, and then there's supporting the pregnancy for after things have gotten out and are going back in. So there's, we break it down into multiple parts for that way you just don't get information overload. Similarly, for how each of the parts works and a lot of the details, we'll actually get you about a 40-minute video that explains things. I used to do a 1-hour-long monologue on it. Everyone's eyes would glaze over about 10 minutes in, and so you get to watch that to understand a lot of the basics of IVF through that as well. I'm going to talk some more of the broader theory on things today, some of the big choices, okay, what is it, why do we do it, all these things that people add on to it, are those necessary or do those help? And so we'll talk about a lot of those things. Now, what is IVF, by the way? Really basic, but it's in vitro fertilization. The reason for that, in vivo fertilization means it's done in the body, so people conceive where the sperm and egg find each other in the body. For in vitro, that means it's outside of the body. And so we're putting the sperm and egg together outside the body, and then when we've got a healthy embryo, you're putting it back in. That's why we do it. I think the overwhelming reason for IVF is control. This gets into another thing which I was going to ask or address later, which is who needs it? Well, normally, if you can get pregnant spontaneously, most people don't need intervention from a doctor to help them along for it. If it isn't working for getting pregnant spontaneously, then you end up saying, okay, let's do something low cost, low tech, and there are a lot of options for people on that. It's the people where those aren't working or have special situations, like they have want to avoid a baby having cystic fibrosis or sickle cell disease or things where they're really serious problems, and you're trying to say, how can I have a more healthy child? That's where IVF can come in, or to again cover or address a lot of the problems for regular subfertility. For example, if there's a problem for the sperm and the sperm can't find an egg, if you do in vitro fertilization and you do what's called intracytoplasmic sperm injection, normally it takes 10 million sperm for one to find an egg. Well, if you're doing IVF and you're putting the sperm directly in the egg, you only need one sperm. Or you might need more than that to find the healthiest or best looking one, but you can get away with, rather than tens of millions, you can do it with tens, for example. Though usually, again, as you start getting below 20, 30,000, you start seeing some really meaningful hits to the quality of the sperm. But again, still, I've had people get pregnant with as low as 30 sperm relative to 30 million, which would be more normal. Similarly for the eggs, well, usually if people don't release eggs, you can give medication that causes that to happen. But at the same time, if there are difficulties for even having that occur, or there are problems for getting the eggs to grow, or for instance, there's tubal disease where sperm and egg can't find each other. Louise Brown, the world's first IVF baby born July 25th, 1978, her mom had tubal disease. And so they got the eggs out and put the sperm directly with the egg, making sure that they found each other. But also the advantage is numbers, and we'll come back to that. But again, if you are having one egg in a month to try to conceive, all of a sudden if you get 25, that's a lot more opportunities that there is a normal egg in the midst of all of those for potentially working. By the way, Brittany, if I start saying anything crazy or I don't realize what I've said, intervene, interject. I always say it takes a village not only to raise a child, but to conceive one. We are interdependent here, and we really appreciate every single team member, and we all help each other. And again, if you also see anything that doesn't make sense, let us know. We can explain it, and we're happy to do so at any time.
One thing, people with tubal ligations, they often think, can they still do IVF?
Oh yes, really good point. Again, for tubal ligations, people think, oh my gosh, do you have to reverse the tube in order to get pregnant with IVF? No, you don't have to do that. You can have the tubes completely removed. And if the tubes, it's harder to repair them than many realize, because it's not just whether the sperm and egg can find each other and whether the tube is technically open, but the thing is, while the sperm has a tail and can swim, the egg doesn't have a tail, it can't swim. The embryo doesn't have a tail, it can't swim. So the function of the tube to bring sperm and egg together and then get the embryo back to the uterus, you can take a lot of damage even if it's technically open and sperm and egg can't find each other. In fact, a lot of people who can't get pregnant spontaneously or through lower cost, lower tech methods, it's because there's some degree of hidden or underlying tubal damage slowing them down. And then also there can sometimes be uterine factors or other things that get in the way, but usually IVF is primarily overcoming a lot of sperm, egg, and tube issues for when people want to get pregnant. Now, who gets pregnant? Everyone always is saying, oh my gosh, this person was lucky or this person was unlucky. Most of the likelihood as to whether or not, by the way, I'm just clicking a few likes for all the people that are out here, and there's so many good family, and I've got to give credit to everyone here that we love you and we appreciate your being here. And thank you for Aaron for the kind words for things. In terms of who gets pregnant, so many people will throw things at you and say, oh, you've got to have CoQ10, or you've got to have acupuncture, or you've got to have bed rest. And all these things really are a minimal impact on it. The overwhelming question, again, is good sperm, good eggs, and having a healthy place to go in the uterus, as well as if there's any inflammatory conditions that have to be restored. Amanda tried the reversal and it didn't work. Yes, again, unfortunately, we wish reversals worked better than they did, but it's all the people who've had reversals, they always say, well, I was previously fertile before, but it's not just a measure of whether you mechanically open the tube or not. There's more that goes into it. It's a bit more complex. The thing is, it's really, again, about good sperm, good eggs, and having a good place to go. And for people who have plenty of, sperm, that works really well. But if you have really bad sperm, or let's say you have a vasectomy, you can often still get good sperm. They're just blocked from getting out. Hey Deborah, hi Michelle, all kinds of people I've been meaning to say hi to. You can still take them directly out of the testicle and still have plenty of good sperm to find an egg. However, if a guy has really low counts because of weight issues, sometimes that can be reversed, sometimes not. If they have problems where the brain is not sending the right signal to the testes, sometimes you can reverse that, sometimes it is not. Sometimes you can have testicular failure, and then there's really poor quality to the sperm. That's where sometimes it's a little bit harder, and you see lower chances with those people. And again, for statistics, and again, doing off the top of my head, I think these are still to come out, but roughly for the last year published for IVF success rates in the US for 2017, around 55% of women under 35 brought home a baby from a single cycle of IVF. For our 2019 statistics, now it's excluding advanced endometriosis, ovarian failure, a few things where people had few eggs, but if you had 15 or more eggs and we did IVF, our statistics were 82.5% would bring home a baby. And if you account for the fact that several of the ones who didn't get pregnant with that were really bad male factor or recurrent pregnancy loss, a lot of the people who would think that they'd get pregnant, but we can give them their odds in advance and ultimately give them different counseling. Similarly for the eggs, again, it's a number and quality. If you're under 30, it takes about 4 eggs to get a good blastocyst, and usually the quality is good for under 30. As you start getting into 35, you might need more 5 eggs. As you get to 40, it might need 6 eggs. Hey, Tori, I'm going to answer a bunch of questions. And by the way, there are a lot of people popping up, and I'll go on a tangent, get to those, and then get to some of the other things. But to finish this out, if you have 25 eggs, and you need 5 eggs to get a good blastocyst at 35 on average, that gives you 5 chances. And so for the people who are less assertive about IVF and only get 10 eggs, they only had 2 chances for getting pregnant out instead of 5. Oops, I've got to move here. The motion sensors for the lights, everyone waves around, goes in the dark here. Energy efficient, respect the environment for everything here. So, how many eggs you get initially matters, but then also the quality. And age is a very good proxy for the quality, but not universal. You can see people at 35 where almost every egg is chromosomally normal, and you can see it where at 35 almost everyone is abnormal. And so this is something you don't usually know without PGT. Now, I'm going to go back up and just answer a few questions for things from everyone. For how much is IVF from Tamika, she was asking. So the answer that's always right in medicine is it depends. For ballpark things, we can do mini IVF where you're not using much or even any injectable medications for around 8,000. The problem is with mini IVF, and it depends on the person, you're often getting 6 eggs if people have normal ovarian reserve, or 6 eggs, 8 eggs, something on that scale. If you're doing full eggs, and again, if people have diminished reserve, they may not get as much, but you can often get 20, 25 eggs. So that will triple the yield or the amount that you have to work with. That's why you can often get a lot more and have more chances for things. So mini IVF often has a lower pregnancy rate than regular IVF, but it is the right thing for some people. Mini IVF is around 8,000. For us, full IVF is about 12,000, but that doesn't include the medications, which can often be $5,000 to $6,000. Now, that's not including people's testing. We try to minimize people's costs for testing, so that's also an issue. But then the other thing that people are looking at for the costs, we bundle a lot in. We include typically for our packages, again, up to 4 transfers. You bring home a baby, run out of embryos, or you get 4 transfers. So we don't nickel and dime people. That's including anesthesia and all kinds of other things. So, and in much of if you include the medications can often be 5 or 6, so that'll bring you into more of an 18,000. You look at much of the U.S. where they advertise 12, 14, but the true cost when you look at, oh, they added on ICSI, oh, they added on assisted hatching, all those, many people pay about 28. So there's a lot of hidden costs. We try to be as transparent as possible about things, and we don't tend to nickel and dime people. But it doesn't include pre-implantation genetic testing. Now that was something I was going into later, but let me explain what PGT-A is. So PGT is when you develop an embryo, you go to day 5, and then you biopsy it. And you're saying, okay, is the embryo chromosomally normal? Now, not everything is perfect for the biopsy. Sometimes they don't generate signal, and sometimes, the biopsy isn't correct. But we often think that biopsies are now getting closer to the 98, 99% chance of being correct, and artificial intelligence algorithms are getting better at that. It's interesting, people talk a lot online about mosaicism, and that's a separate issue for it. Whether or not it says that it's normal, but it's actually abnormal. It says that it's abnormal and it's actually normal. It's interesting, when humans were doing more of the screening, they didn't really want to call a abnormal embryo normal, so they erred much more on calling it abnormal, then it never got transferred. But there was some data that if you transferred abnormal, they'd be fine. Some of that related to the fact that humans were overcalling the normals as abnormal. As you give artificial intelligence, so computers which don't have that emotion or nervousness or things like that, the screening, you're getting more of those normals being called normals, and that's sort of correcting that. The other thing people worry about is for mosaics, hey, what if it's again, completely abnormal, completely normal, or then there's these high-level and low-level mosaics. And we're right now at a point where some have a little bit of variation in the DNA, but they are mostly normal. Those are considered low-level mosaicism, and they do tend to miscarry a bit more than the sort of high-level mosaics are completely abnormal appearing embryos. But we're getting to a point where we may even transfer some of those, even if they aren't our first line. The high-level mosaics, though, usually have a much, much lower chance of actually taking, and a lot of people tend not to transfer those. One other thing, let's see, just going for the questions here for things, you can get pregnant naturally but keep miscarrying. That's a recurrent pregnancy loss question for Bianca. That's a really great topic. We actually have a whole nother Facebook Live on that. If you search through our archives on for the First Friday Lives, you'll see one for RPL, or recurrent pregnancy loss. That is one we did a whole session on, and it's really good. I think I could talk for a full hour on that. I won't do that one for things. Let's see, had 8 eggs removed after your son. He's 5 now, you're 26. You had your 8 ovaries removed. Hannah, it's an interesting way of things. I think you're phrasing that you had 8 eggs removed for IVF, the question that I think, Hannah, you may need to rephrase your question, but if you had, it might have been right instead of 8 ovaries removed. Right ovaries removed, so it's interesting. If you remove one ovary, you often see it ages the effective ovarian age by about 3 years, a little bit, for pregnancy rates, or at least how you compare to menopause for people. And so if you are 26 now, you're more likely to be 29. Often many people can still get pregnant. Again, it would have to be individualized. Again, everything we say is general medical advice on this, and we'd customize it to you getting to know you. But at the same time, you do see an aging of the ovarian reserve, and you see sometimes the remaining ovary can compensate for it, but not always. So you have to see where you stand individually. But usually at 26, there's a lot of hope for things. Yes, Amanda is giving great advice for the fact that you can get places for discounted medications, and so you can get lower costs. Deborah's asking $18,000 for one try. $18,000 roughly is for one retrieval. But that would, again, we like to think that it would cover multiple attempts because we try to get multiple embryos for people so that there's buffer. So if you're pregnant, we cheer, but if you're not pregnant, or you're pregnant and you miscarry, or you're pregnant, deliver, want to get another kid, you don't go through IVF again, you just do another transfer. For how we're covering transfers though, if you've had that first child, the fact that we bundled in the extra was to get you to that first trial, but for that first child. But again, you can argue whether you call it one try or not, and that gets to semantics, but I like to think of it as multiple attempts, because if we generate 6 blastocysts, we're not putting all 6 back and making you Octomom. We're giving you one and playing it safe, but then there will be others to work with if it didn't take, and it's not as though you'd have to start all over again from scratch. Explaining some of the things, for PGT, I think I went into that a little bit, but to come back to it, that's the biopsy of the embryo to see if it's chromosomally normal. We're moving much more towards that as a field. Now again, not everyone needs it. I'm a big believer in autonomy. It is people's bodies. They get to decide what they do with it. But if you're in your early mid-20s, even late 20s, you probably don't necessarily need PGT to get pregnant because a lot of your embryos are normal. I've seen exceptions. This is not to say that's universal. Similarly, if you're 40, you probably won't have a ton of spare embryos, and as a result, you might only get 1 or 2 and would want to put them back. But in both those circumstances, you can make a case. Now, mid-30s is where I lean most towards PGT, where you've got a lot of embryos, but then at the same time, you don't know which are normal. And so that helps to select from among them. For the 40-year-old, though, even if you have 1 or 2, some people end up saying, well, let's end up not doing the biopsy and just see what happens. We recently had a case where a person may have Down syndrome having done that for a baby. And, again, these can be wonderful children and are greatly loved and things like that. But some people would want to know before putting back an embryo with Down syndrome, and may choose not to do so, or they may choose to do so, but that's information some people would value. Similarly, for the people in their mid-20s, they are likely to get pregnant when you can include up to 4 transfers or bringing home a baby, or using all the embryos that are there for how we bundle things. But what will happen is a lot of people get pregnant on the first transfer, and then they have 3 or 4 embryos frozen. And then they're saying, okay, I'm ready for another kid, but do I really have 1 embryo that's normal, or none, or 4? And they don't know. Plus, if they're paying for those transfers downstream, if they pay for a transfer and it was of an abnormal embryo that wasn't going to take, it would just dissolve on its own. They may have spent that money for the transfer on something that didn't have a chance, and would have just, if they paid it up front for PGT, that would have covered it. So that's something where a lot of people would be leaning more towards paying it forward, so to speak. But I don't think it's not for everyone. It does add a cost, and it can be in the sort of $4,000, $4,500 when you look at some of the multiple components to it. And some people, if they're likely to get pregnant and don't want to spend that money at that time, going with just a simple unbiopsied embryo makes a lot of sense. Would IVF be the next step after IUI? Avita is asking. That's a great question. First, I think it really depends for people. And I think, it's not just whether you do IUI, but how was IUI done? Were you getting a reasonable number of eggs? Was the sperm decent? How many attempts did you do with the IUI? And how much are you paying for IUI? Some people, a lot of the U.S. is paying double, triple what we charge for it. Many people, if they don't get pregnant in the first 3 IUIs, can go on to another 3. But some people are also saying, I'm exhausted. I just wanted to be pregnant yesterday. Let's get it done. And IVF greatly revs up their fertility, and that's the right step. But other people, it's adoption, it's child-free living, it's using egg donation, which is still IVF, but a different approach. I think, the one thing, back to what I said before, where the right answer in medicine is it depends, I think people have to understand where you are, know your body, and ultimately choose what is individually right for you, and then adjust to that. So these are all very good questions for everything. We've talked about pre-implantation genetic testing. Assisted hatching, honestly, we bundle it into IVF, so it's not as though if we were to do it, we'd nickel and dime you for it. We do it for people where we think it benefits. Generally, as you start getting above 35, and especially above 38, you start getting a hard zona around an embryo. This is sort of like hatching out of the shell for a chick, so to speak. And so sometimes we'll assist it by making the shell more open, the zona pellucida, so that the embryo can hatch through. Another thing is if you're doing PGT, where you're biopsying the embryo, you actually have the embryo sort of hatch through the laser, using a laser to help it open up next to where the future placenta is. It's called the trophectoderm technically. Tammy's just saying, needing a miracle at this point. We'll take miracles. We celebrate it. I always say, by the way, I don't care how people get pregnant so long as they're successful. We will do whatever it takes, and we really hope for everyone to get the family they want. Hey Dale, for the wait for IVF looking like now this year, if we want, great to see you. That is a great question. By the way, I've forgotten to like a lot of these things, and I appreciate all the comments and feedback here. It's interesting, in sort of May, June of 2019, we were booking out to September for being full. With COVID, that sort of threw things a lot. I think we're pretty much full for July right now, but we can do things in August, so there's a lot more flexibility as a result of COVID. We're still doing well, and we batch and we do quality control where we only allow so many people to come through, but we'd be happy to get you in this year for things. However, let's segue and use that into another topic, which is fresh versus frozen. Some people are doing, we used to classically as a field do fresh transfers. Now a lot of people are moving towards frozen. I think that overlaps a little bit with PGT. If you're doing PGT, almost everywhere it takes a while to get the results back from the biopsy. And so you pretty much have to freeze the embryos before you get pregnant using biopsied embryos, because you want to get the results back if you're doing that effort. Whoops, we got the motion sensors going again for a second. Let's just wave around so they can get the lights back on. I am very flexible on this. Again, what is right for a person? Now, for me, for fresh, if a person is hyperstimulating, I think they need to recover. And everyone has a degree of hyperstimulation. If the embryos are poor quality and we don't think they would survive a freeze, some people say, hey, if they wouldn't survive a freeze, they won't take anyway. That's not always the case. There's a trend towards that, but not always the case. And I think most people would rather feel that they got a chance rather than not. Now I'm going to gloss over and skip over this for day 3 versus day 5, and then I'll come back to fresh versus frozen. I wrote a book chapter a few years back where it was blastocyst transfer for everyone, and I was supposed to show this balanced approach to things for whether or not we do day 3 versus day 5, and I was going to make a case for both. And as I went over 200 papers for this thing, I pretty much became a day 5 only person. Again, I'm open-minded, respecting people's autonomy. If they want to do day 3, they can. But for me, the reason I lean much more towards the day 5 is I think the pelvis needs to cool down a little bit from the hormones and being revved up from IVF. And also it allows the embryo to declare itself more. Where again, a lot of the sperm is less active the first few days of life. That's much more the mom's DNA. And as you get to day 5, the male DNA kicks in. And so if there were a problem with the male DNA, you wouldn't really see it as well early on. Hannah's asking where we located. We're in Madison, Mississippi, but we also have satellites throughout Mississippi and Louisiana. We're expanding, and there are a lot of things, but we routinely I have one patient getting care from Maine. I have another we were caring for earlier this week from Missouri. We have people even coming from Spain, so we're used to seeing people from all over the country for where we provide care for things. You don't necessarily think of Mississippi as a fertility tourism destination, but in terms of being able to get high value, by which I mean really good pregnancy rates at low cost relative to much of the country, we are very proud of what we can do on that. Coming back to the fresh versus frozen for things, I think so again, two reasons for fresh, or where you wouldn't do fresh, is you need people to cool down for over response, or you are worried embryos won't survive a freeze. Conversely, there is a little bit of a strain on embryos for doing things with a fresh cycle, but also for freezing, it creates a strain as they're frozen, but it's not much. Vitrification has gotten much, much better for survival, and the technology is greatly advanced in the past decade. So vitrification with high survival rates is very much the norm now. The challenge, I think, also, where a lot of people say frozen is better than fresh, because a lot of people have done PGT, where they biopsied the embryo, and as a result, you're knowing whether an embryo is normal or not after freezing. But that's sort of cheating or looking. That's not that the freezing helped, it's that you got an answer about it. I'm hearing the ventilation system come on. Could you pause that for a second, Brittany? For just over there, just turn the fan off for things. Just so you don't have that background whirring noise, and so you guys can actually hear me a little bit better for things. We sometimes get audio input for stuff. Try to use the boom mic so that it comes in a little bit clearer. Here, I'm bringing it down a bit, possibly get my voice a bit better. Another thing that a lot of people are talking about is endometrial receptivity assays, where you're biopsying the embryo to see if it's or the lining of the uterus to see if it's normal. I'm personally not a huge fan of this. I think if you have recurrent implantation failure, where you are actually putting embryos back and they're not taking, that by all means, I think people should get, see if there's anything for the endometrium. But because most people end up having a normal uterus, and let me come back to that, we see much lower yield for it changing our management when we've done it. Not to say that there aren't exceptions, but a lot of the people where they've had the timing for putting an embryo back relative to transfer being changed by the endometrial receptivity assay, I think that some of that is because they didn't get good evaluations of the uterus to begin with. We do office hysteroscopy, and so we're taking a fiber optic camera the dimension of a coffee straw, looking directly inside the uterus where a baby grows. We can actually see a lot of things that are missed with a blind biopsy that samples 4% of the uterus. So the ability to sort of see the uterus and see if there are problems that need to be fixed, I think direct visualization is better than just a small scraping of the uterus to see if there's something blind or random there. And this is, again, a lot of the things that I talk about. There's a lot of voodoo out there that people are saying, and you'll always have the person, nothing worked, and then I took Lovenox, or I took this herb from the Middle East, or I took, all this random stuff, when in fact so much of it, again, is having also not only good sperm, eggs, and a uterus, but having the proper evaluation from them from someone who knows what they're doing. And I would also say a high quality lab. There are a lot of labs, hey Julie, good to see you. There are a lot of labs that are not necessarily good quality, and people don't realize that their chances weren't that good going to that place. And I think that does so many people a disservice. There are people who will forever go back to an empty home as a result of going to a place that had below standard care. And I think the more you can do to promote success, the more it is doing right by those entrusted to you. And so we believe very deeply in finding the right balance of doing as much as you can that is right for the individual and being effective. And I think that comes back to a core thing. I always say it not only takes a village to raise a child, but to conceive one. I said it before in this. I have so much respect and appreciation for everyone on the team. Brittany was up here, but you've got Vicky, you've got Lauren, you've got Cynthia for the clinical aspect of things, Dr. Dorman and Mandy for the embryology and andrology, and then of course also Lindsay and Tracy and Melissa for sort of the administrative aspects of things. Everything we do, I couldn't do it without them. I always say, 80% of the reputation of a doc is based on the rest of the team. I appreciate the people who come here and appreciate us, but I have to give great credit. It's not just me. I'm very blessed and fortunate to work with a lot of good people. And for those of you whom I know and met, you can speak to that. And for those of you I haven't met, I hope you get the chance to come see it for yourself. I've gone on way longer than I normally do for this thing, and so and that's the phone's ringing off the hook now that we've just gotten past lunch break, and so I will switch over to other things. But God bless, good luck, and please ask away for questions. If you ask questions or post after this is done, I'll probably see them and I'll be able to give some feedback. But again, a lot of the best advice we can give has to be individualized and customized to you rather than general questions. Have a wonderful day and summer, and we will hope to see you.